Good morning, everyone. It is Tuesday and January the 12th. It's 9 a.m. here in Cleveland, Eastern Standard Time. My name is Ashok Agarwal. I'm your host for the next 2-3 hours. And I want to, first of all, before we begin the program, want to wish you a very happy New Year 2021. I wish you good health and a lot of happiness, and I hope that we will be able to see many of you during this year after the pandemic is under control. So thank you again. And today is a very exciting program. We are here to discuss and present virtually our online ART training. Today is the third program in the series. We began in November. We presented first program in November, then second one in December, on December 8th. And today is our third program on January the 12th. Today's program is on Ancillary Semen Test. So let me begin without taking any further time and begin my introduction. Very briefly, this is my biography, a very brief biography, just to provide few highlights. I am in charge of the Andrology Center at Cleveland Clinic for the past 28 years. I'm the director of the American Center for Reproductive Medicine, which is the host of this online virtual training session. I'm a professor of surgery in urology at the Lerner College of Medicine at Case Western. I'm a staff in urology and in some other department. Our group is very well known in the area of male infertility, andrology, and human-assisted reproduction, and we are ranked as #1 in terms of our publications based on the Scopus, which is one of the premier service in terms of the literature in the medical field. Our group has published a very large number of books in the field of male infertility, ART, fertility preservation, DNA damage, and antioxidant. Our laboratory has trained over 3,000 scientists, clinicians, graduates from more than 100 countries. The organizers and speakers of this program have no conflict of interest. We have taken no sponsorship or asked any company for that. This program is made entirely possible by the support from our foundation, from our own center, and the webcasting support has been provided by our colleagues, David Reichling and David Wolfley. Course faculty have generously donated their time for this online training, and our program coordinators, who you will see in a minute, have graciously volunteered their valuable time to manage this program. Lastly, the names, images, and description of products or instruments that you may see during the lectures or which will be discussed during the presentations are not being endorsed. They are being used routinely in our program. So this is today's program. The learning objectives today is we have a very, very good program today, and you will see this is part of the semen analysis, and it is like a hidden gem. Most people will not know many of these tests that are basically done as part of semen analysis as indicated, So we are going to discuss about the leukocytospermia, or detection of white blood cell or infection, sperm vitality testing, anti-sperm antibody screening, special test for azoospermia, post-vasectomy screen, and screening for retrograde ejaculate. So I can tell you that today's program is by far going to be the very best. We have invested enormous amount of time in preparing for these lectures. They have been well researched, well prepared, and practiced dozens and dozens of time what you are going to see today. So for each lecture, we have spent almost 30-40 hours minimum in practice sessions, and each lecture has gone through at least 10 or 12 practice sessions with multiple people, and each content has been well researched through the literature with proper references, and to make sure everything is extremely accurate and simple for you to understand. So this is our program today in a diagram. As you can see, the last lecture is going to be by our clinician, who's going to really put it all together to explain what these tests really mean to you. Dr. Sharma spoke very nicely about a little known test called vitality test, and he explained the differences between vitality and viability. Two very important differences, one for diagnostic, one for therapeutic. And now we dive into the next topic, which is on anti-sperm antibodies. And our next speaker is Dr. Sejal Gupta. Dr. Gupta is a veteran of our andrology program. She is the technical supervisor of our center, which runs 3 laboratories in different parts of Cleveland Clinic, in different cities. And also we have a very large reproductive sperm and semen bank for cancer patients. Dr. Gupta has a distinguished career. She has done her fellowship in reproductive medicine with WHO, and then a research fellowship with our program. She has been highly decorated, as you can see. She has also done a master's in embryology from the Jones Institute. She is a very passionate andrologist who really takes care of our patients in the most compassionate manner. And today I invite her to speak about the issue of anti-sperm antibody test. So Sejal, you can present if you want.
Thank you very much, Dr. Agarwal, for the introduction, and welcome to all the participants. Good morning from Cleveland. And the presentation that I'm going to be making is on anti-sperm antibody test. Next slide. The learning objectives of this talk are indications for anti-sperm antibody testing, review the principle and protocol for the technique by which we do the anti-sperm antibody test, which is the mixed antiglobulin reaction, and in short, it's called the MAR test. Learn scoring, calculation, and reporting of the results by this test, and recognize the importance of quality control, quality assurance, and troubleshooting. Next slide, please. So this slide illustrates the indications for sperm MAR test. So the most important indication is sperm agglutination, which could be mild, moderate, or severe. And on the right side, you can see on the illustration the presence of sperm that are agglutinated to each other. The second is low total motility, low progressive motility, vasectomy reversal. Any disruption in the barrier of the blood testes barrier can result in formation of sperm antibodies. Scrotal injury, which again leads to disruption of the barrier, previous miscarriages, and poor IVF outcomes. Next slide. So the equipment and supplies that are needed for conducting this test are the bright field microscope using the 20x magnification, phase contrast, and with the green filter. The others are what are listed are the incubator and some other supplies. And finally, what is needed is a fixed cell sperm counting chamber and a humidified chamber in which the samples are incubated. Next slide. So the reagents listed are, and we have provided the illustrations on the right side. The first important reagent is the MAR test IgG kit. And this kit is illustrated as the first illustration, and it is labeled. So this has initially the suspension of the polystyrene latex beads, which are 2 micrometers in diameter, and these are coated with the human IgG. And then there is the MAR anti-serum, which is containing the monoclonal antibodies towards the fragment C of the human IgG. The second important reagent is the controls, which are the positive and the negative controls. And these are run in the assay to make sure that the assay is run correctly. The third illustration on the top is the IgA kit. So this IgA kit has the latex beads and the anti-serum in a single solution. And you can see our technologist at the bottom. She's performing the sperm MAR test. Next slide. What is the principle of the MAR test? Essentially, there are 3 immunoglobulin classes, IgA, IgG, and IgM. But in the semen sample, the main antibodies are IgA and IgG. And what leads to the antibody production is the autoantigenic properties of the spermatozoa. And on the right side, you see the illustration where the beads are attached to the spermatozoa and the beads are coated with the antibody to the IgA. And these will attach to the sperm-bound IgA antibodies. So basically, there is a bridging antibody which is connecting the beads to the spermatozoa. And the motile spermatozoa and the beads will form mixed agglutinates, and that's why it's called a mixed antiglobulin reaction. And it can be tested against both IgA and IgG antibodies. And the binding of the beads indicate the presence of IgA or IgG antibodies. Next slide. So here I'll show you a short video clip of how the test is performed, the IgG test. And you can see there's a humidified chamber. So the slide is labeled, the semen sample, 10 microliters is placed on the slide. Next, we place the beads from the IgG, 10 microliters, and then the semen and this beads are mixed well. Next, we take the anti-serum 10 microliters and add it to the mixture, and then mix the sperm sample, the beads, and the serum. And then a cover slip is placed on the slide. This slide is placed in the humidified chamber. We place a timer for 3 minutes. So once the incubation is done, the reaction has happened, then this slide will be examined on the phase contrast microscope. Next slide, please. So what is the significance of positive IgA and IgG antibodies, which are both tested in the semen sample? The IgA antibodies have greater clinical importance than IgG antibodies. Essentially, the beads will bind to the motile and immotile spermatozoa, which have the surface-bound antibodies. And this is illustrated in a very nice illustration on the right side, the binding of the beads to either the head or multiple sites of the spermatozoa where they are bound, and the percentage of motile spermatozoa with the bound beads is recorded. So the important thing to understand is just count the motile spermatozoa with the bound beads. Next slide. Here, what are the quality reagents? The quality control reagents are basically decomplemented patient serum, which is diluted in cell culture medium, and both positive control and negative control is provided with the kit. These are warm to room temperature before use, and the shelf life is about 18 months. Next slide, please. So here I've provided a step-by-step protocol of how the MAR IgG positive and negative controls are run. So the first step is to vortex both the controls well before use. And the second step is we use a known negative. Known negative means this donor sample. It's a normospermic subject, and his sample was already tested for antibody and was negative. And this sample, to this sample, we add modified human tubular fluid, twice the sample volume. And once we have added the HTF, this is mixed well, the step 4, and then this sample is spun for 10 minutes at 1600 RPM. And once the centrifugation is done, the fifth step is to remove the supernatant and leave some of the supernatant, about 100 microliters, to mix the pellet. And this last step is used, washed donor sample is used to test the negative and the positive controls. And this I will illustrate in a video clip in the next slide. Next slide, please. So here, the semen sample from the donor is there, and then modified HTF is added, twice the volume. This mixture is placed in the centrifuge for 10 minutes. The aspiration of the supernatant is done. The pellet is left undisturbed. And then the pellet is reconstituted with some more fresh modified HTF. And the concentration should not be higher than 50 million. So this is the positive control. 50 microliters of the positive control is added to the amber-colored vial. And then the donor sample is added 50 microliters. Same is done for the negative control. And then once the mixture is in the vial, these vials will be incubated for 1 hour for the reaction to happen. And then the actual testing will be done with the IgG beads as well as the IgG anti-serum to check whether the positive ran positive or the negative ran negative. Next slide. So to examine the sperm MAR test scoring, what are the basic principles? The latex beads bind to the spermatozoa with antibodies on their surface, and there could be few beads or multiple beads that may attach to the motile spermatozoa. So as a result of the binding of the beads, the motility is reduced, and especially when there are large clumps of beads binding to the spermatozoa. The sperm, which do not have the antibody coating, will swim freely between the beads. So we will count only motile spermatozoa, and a total of 100 is counted, the ones that are attached versus the ones where there is no bead attachment. The ultimate goal of this test is to evaluate the percentage of motile spermatozoa with the beads attached. Next slide, please. So going further, how do we read the results? We use the 20x objective, as you can appreciate in the illustration on the right, and use the phase contrast with the green filter. And then count 100 motile spermatozoa twice to assess the percentage of sperm binding to the beads. What you report is the average of the two values you have obtained, and the test is reported as positive if greater than or equal to 40% of the sperm have beads attached. And this is per the IgG kit, the manufacturer recommendations that any test where it is greater than or equal to 40% binding should be reported positive. Now, as per a publication from Human Reproduction from Lotti et al., they have reported a prevalence of MAR test positivity in the 5 to 15% of infertile males. So it is an important cause of infertility. Next slide, please. Here I have an illustration of a negative control sample. So you could play the video. And what I want to show is basically there are beads, clumps of beads, but the spermatozoa are predominantly swimming or moving freely, so they are not bound to the beads. And so we have the negative control run as a negative, and we know the test is performed accurately. Next slide, please. Oh, there was another one. Please go back. The positive control. So here you will appreciate the positive control. And what I want to show you here is the clump of beads and the spermatozoa that are attached in this clump, and they're attached either by the tail or by the head, but they are basically bound to the beads. And so this was a positive control. Reporting of results, negative results are reported if less than 40% of the sperm is bound to the beads. Positive results, how do we report and record? Positive if greater than equal to 40% of the sperm is bound to the beads. We report the person binding, and we report the area of bead attachment, whether the head, mid-piece, because if it's bound to the head, then the clinicians have to make a separate judgment call. And on the right, you can see and appreciate the different areas where the sperm is bound. The first one shows the binding to the head. The second shows to the tail. At the bottom is a negative result where there is sperm that is swimming and there's no binding. Next slide, please. So quality control is an important component of the anti-sperm antibody testing. And in our laboratory or other laboratories perform the proficiency testing. So this is an example of two analytes. We are sent two analytes, and the numbers are provided 17 and 18 by the College of American Pathologists. So the first analyte with the red box shows 4% binding. It is negative. The second analyte shows 87% binding, and it is positive. And then the negative and the positive controls results are also shown. The positive control, 97% positive binding. Negative control, there was 13% negative binding. So we know the results are accurate, and this is what we report as part of EQC. Next. So these are the results for both the analytes, and the intended response matched what our results were. So the lab is performing the test accurately and reporting the results well. Next slide. So here is a scenario for a negative ASA IgA test. And this was an IgA ASA, or the anti-sperm antibody test, performed for a sample with sperm concentration of 15 million, motility of 45%. How do we calculate the percent total binding? It's number of sperm with bound beads upon total number of sperms counted and reported as a percent. So when we examine under the microscope, what we saw was free total motile 75, bound total motile 25. So the percent total binding is 25%, and the result is ASA IgA test negative. Remember, the cutoff is greater than equal to 40%. Next slide. This is scenario 2 that is illustrating a semen sample with low motility. So this was a semen sample with 5% motility. And these are the patients where anti-sperm antibody is ordered by the physicians, and a concentration here was 2 million. When the sample was examined under the microscope, there were less than 100 motile sperm on the wet prep. Person binding cannot be reported due to very few motile sperm, and hence the result was not reported to the clinician because of very low motility. Next slide. So this is a recent study published in Human Reproduction, which examined the significance of positive MAR tests. So on the first panel, the bar diagram shows percent of men with MAR test positivity. They took a cutoff of greater than 50%, and this was examined in males of fertile couples versus male of infertile couples. And you can appreciate that there was significantly higher number of positivity in males of infertile couples. The second bar diagram shows comparison of positive MAR test and negative MAR test in men with history of epididymitis. Epididymitis is, again, there is a disruption of the blood testis barrier, and what they have reported is a higher percent of MAR test positivity in patients with epididymitis. So It can be positive in patients with orchitis as well as in patients with epidermitis. Next slide. So I would like to sum up with some take-home key points. MAR test is useful in the diagnosis of immunological infertility. It is important to test for both antibodies, IgA and IgG. And anti-sperm antibodies do play an important role in male infertility, as has been demonstrated by several publications. And proficiency testing, or EQC, is an important tool for reporting accurate anti-sperm antibody results. On the right, you see our andrological evaluation of male infertility. This has the protocol for the MAR test provided in it. Next slide, please. So this is our group in front of the Andrology Center. And I thank you all for your attention.
The speaker here is Dr. Neel Parekh. Dr. Parekh is a clinical assistant professor, a young man in the Department of Urology. He did his fellowship at Cleveland Clinic in andrology and male infertility 2 years ago, and went on to join the staff after he completed it in the summer of 2019. He has a lot of surgical experience in a variety of urological procedures related to microsurgery and male infertility, as well as erectile dysfunction. So Neel has been a very important part of this lecture series that we are doing, as he's going to stitch together all the tests into providing a clinical interpretation of a variety of tests that we have discussed today. We discussed 6 different laboratory tests which are part of the semen analysis: the leukocytospermia, the vitality test, the anti-sperm antibody, the special test for azoospermia. We talked about the post-vasectomy semen analysis, and lastly, Dr. Gupta spoke about the retrograde sperm count. So without any further ado, let me mute myself first. Okay, for this. Okay.
Hi everyone, my name is Dr. Neel Parekh. I am a clinical assistant professor in the Department of Urology at the Cleveland Clinic. Today I will be sharing with you the clinical interpretation of laboratory results. By now you should have heard lectures from Dr. Henkel, Dr. Gupta, and Dr. Sharma, and have a better understanding of some of these specialized tests, and we'll discuss how we use them in the clinical situation. Let's start with the first clinical question. We have a patient who is being evaluated for infertility. He has a semen culture and semen analysis performed. The report shows a positive semen culture. However, it is negative for leukocytospermia. What is the management strategy? Now, this is something that we try to avoid on a routine basis, but does commonly occur. We try to avoid a positive semen culture in the setting of negative leukocytospermia by adhering to the strict hygiene protocol that the WHO recommends. Furthermore, we recommend that patients urinate before they provide the semen analysis. Unfortunately, skin fluid contamination may be unavoidable, as we see in this situation. Contamination can be seen because as much as 71% of the bacterial strains colonizing the coronal sulcus of the penis are also present in the distal urethra. There is also significant controversy regarding the role and utility of semen culture. It has been shown that no significant difference exists within the presence or absence of bacteriospermia in achieving pregnancy. And there are no strict guidelines that revolve around the management of semen cultures. However, in my clinical practice, I do believe a positive semen culture with leukocytospermia should be treated. Question number 2. We have a patient who has a semen analysis that demonstrates a concentration of 12 million, a motility of 30%, an elevated ENST value of 4.5 million WBCs per milliliter, and a negative semen culture. Will this patient benefit from a course of antibiotics? This is a very common clinical scenario that I encounter, I just want to break it down a little further. So this male with oligoastenozoospermia presents with leukocytospermia. The terminology is also sometimes seen to be pyospermia or leucospermia. Just to avoid any confusion, you can see it written in any of these ways. Just like any patient who presents to my office, we'll begin with obtaining a thorough history and physical examination. It is also important to obtain social history. This includes smoking, alcohol intake, drug use, etc. The reason this is important is because leukocytospermia has also been found to be a cause due to cigarette smoking, heavy alcohol use, advanced age, and not just infection. Here we have an algorithm where we break down the testing required in this patient. So in this patient with an elevated ENS test, and we determine that there are leukocytes present, a semen culture and PCR should be performed. The PCR will allow us to check for gonorrhea, chlamydia, atypical bacteria such as ureaplasma, mycoplasma, and depending on the results of the culture and the PCR, will determine the treatment regimen and whether antibiotics will be of benefit. Now, there's a few different situations that can occur. Of course, in a patient that has been treated with antibiotics but continues to have an elevated ENS level after treatment, it is possible that their social history could indicate why they have a persistently elevated ENS. So if they're a heavy smoker, we may not see their ENS completely normalize. Another important clinical question in this case is, was the partner treated? So an infection such as gonorrhea, chlamydia, ureaplasma, mycoplasma can be transmitted from the male to the female or vice versa. So if you're only treating the male, it is possible for the male to continue to get reinfected if they're still sexually active with their partner. So it is important to document or note whether the female partner has been treated as well. Let's move to clinical question number 3. We have a patient who has a semen analysis that shows normal volume at 2.5 milliliters, normal sperm concentration at 50 million, 0% sperm motility, and a vitality of 40%. So as Dr. Sharma discussed in his lecture on sperm vitality testing, it is indicated in patients with low motility, less than 25%, in either ejaculated or surgically retrieved specimens. From a clinical standpoint, it is important to differentiate between necrozoospermia, which is dead sperm, and astenozoospermia, which is viable and motile sperm. Normal vitality is greater than or equal to 58%. So again, like in these patients, an important history and physical exam is important. So in this particular situation, history elicits a history of recurrent respiratory infections. So in a male with recurrent respiratory infections and immotile sperm, the likely diagnosis is primary ciliary dyskinesia. This is a rare genetic disease with symptoms caused by malfunction of motile cilia. However, even with completely immotile spermatozoa, the use of the hypoosmotic swelling test is a good alternative to identify which spermatozoa may be viable for IVF ICSI. Question number 4. A patient presents for semen analysis and has the following results: a semen volume of 3.5 mLs, a sperm concentration of 35 million, sperm motility of 0%, and a vitality of 0%. How will you manage this patient? So in this situation, unlike the previous patient, this is complete necrozoospermia. So when a patient presents with this diagnosis, it's important to elucidate whether any spermicidal lubricant was used during the semen analysis collection. You want to make sure there was no issue with the collection process itself or any other issue that could result in the necrozoospermia. It is important also to repeat the semen analysis, just as the AUA guidelines and EUA guidelines recommend one semen analysis spaced out by approximately 1 month. If there is no pathological cause, IVF-ICSI has been shown to be successful when using testicular-derived sperm in men with necrozoospermia. Clinical question number 5. We have a patient who presents with primary infertility and with the following semen analysis results. A sperm concentration of 10 million, a motility of 25%, but also moderate to severe sperm agglutination. How will you manage this patient? So another common clinical scenario that I encounter is a patient with oligoastenozoospermia with moderate to severe agglutination. As was discussed in the previous lecture, sperm agglutination refers to sperm being clumped together. This process may impair sperm motility and prevent sperm penetration of the cervical mucus and inhibit sperm oocyte fusion. Now, what can cause moderate to severe agglutination? One common cause is violation of the blood testis barrier. Any violation of this barrier can predispose men to an immune response to sperm in the form of anti-sperm antibodies. So in this patient scenario, what could cause the severe agglutination and the reduction in motility and concentration? So as we mentioned, anti-sperm antibodies, history of genital trauma, as well as testicular or scrotal surgery, for example, a history of testicular torsion or orchidopexy for cryptorchidism, history of genital infections, or vitamin C deficiency. Clinical question number 6. A patient has a history of a vasectomy reversal 1 year ago and wants to conceive with a new partner. His semen analysis results are as follows. He has a sperm concentration of 4 million, motility of 30%, and moderate sperm agglutination. How will you manage this patient, and when do you order the anti-sperm antibody test? So it's important to know that the presence and levels of anti-sperm antibodies following vasectomy reversal are inconsistently predictors of whether a couple will be successful in achieving pregnancy. The reason being is that ASAs, or anti-sperm antibodies, are found in between 8 and 21% of men in the general population, and 9 to 36% of infertile patients. However, up to 100% of men after a vasectomy will have anti-sperm antibodies. So this is a male that has a history of a vasectomy followed by a vasectomy reversal. So there's a strong likelihood that he will test positive for anti-sperm antibodies. So really there is no role for testing in this clinical situation. Now, regardless of the cause of anti-sperm antibodies, the treatment is pretty consistent for men who test positive, or in this situation. I commonly will treat them with a low-dose steroid, typically 1 month of a tapering dose, and there are multiple different combinations of steroids and different steroids that can be used. I would then recommend repeating a semen analysis at 6 weeks after treatment with the low-dose steroids to reassess the patient's sperm quality. Question number 7. We have a couple who presents with primary infertility. The male partner's semen analysis is as follows. Sperm concentration of 54.8 million, a motility of 31%, moderate to severe sperm agglutination, and no female factor. If the couple choose to undergo intrauterine insemination, what special advice would you give them? This is a patient with isolated astenozoospermia. Once again, want to obtain a complete history and physical examination, assess for varicocele or any other pathology. You want to assess for risk factors for anti-sperm antibodies, so any previous surgical history or trauma to the genitalia. Now, the AUA guidelines do recommend testing anti-sperm antibodies when there's isolated astenozoospermia with normal sperm concentration and agglutination, as seen in this patient. However, ASA is not needed to be tested if sperm are to be used for ICSI. That is also an AUA guideline. Now, in this situation, the couple may be interested in pursuing intrauterine insemination. The evidence demonstrates that really no special treatment should be taken prior to IUI. The most important thing is properly timing the IUI with the female's LH surge, and this is the first-line treatment. Now, if they have failure of IUI, then there may be a role for pre-treatment of the male with low-dose steroids, as I discussed on the previous slide. Clinical question 8. So we have a patient who presents with a semen volume of 3 mLs. He has no sperm on the wet prep. Upon centrifugation, 5 sperm are seen on wet prep. How should this patient be managed? So this is what we consider cryptozoospermia, also referred to as virtual azospermia. This is a patient with a very low spermatozoa concentration, less than 1 million in the ejaculate. So here we have an algorithm for this patient. So on the wet prep, there are sperm seen. So this is cryptozoospermia. If no sperm were seen, then you would proceed to more specialized staining, which we'll discuss in the next few slides. So what are causes of cryptozoospermia? Varicoceles, infections, environmental factors, history of malignancy, undescended testicle, endocrine disorders, genetic mutations, previous pelvic surgeries, and certain medications, chemotherapy or radiation therapy can result in this diagnosis. Further workup includes history, physical exam, hormonal evaluation, genetic evaluation, checking for karyotype and Y chromosome microdeletion. And in this situation, where 5 sperm are seen, it is also reasonable on a repeat semen analysis to offer sperm cryopreservation. Now, we can't predict whether or not more or less sperm or a similar number of sperm will be seen on subsequent semen analysis, but I do feel in this situation we do not want to waste an opportunity to freeze sperm that could potentially be used for ICSI and avoid a surgical sperm retrieval procedure if sperm are frozen. Question number 9. So a patient presents with a semen volume of 0.5. No sperm are seen on wet, unspun, and spun preparation. Upon special nuclear fast staining, a few spermatozoa are reported. How will you manage this patient? So, in a patient with azospermia, and after the history and physical exam, which determines the presence or absence of a vas deferens, in this case, this patient did have papillary vas deferens, the next step is to look at the semen volume. So in this scenario, the volume is 0.5, which is considered to be low. So the next step would be post-ejaculatory UA to further assess this patient. So in this situation, with the positive staining, this increases the likelihood of there being sperm, whether it is retrograde ejaculation or an obstruction, or in the situation where this was normal volume azospermia, there's a higher likelihood of finding sperm with a surgical sperm retrieval like microsurgical testicular sperm extraction. So we do use this in clinical practice as far as predicting and being able to counsel the patient on the likelihood of finding viable sperm. Question 10. A patient's semen sample is examined for routine semen analysis. The sample shows normal volume and complete absence of sperm on wet prep. Upon special staining by nuclear fast stain, only 2 sperm heads without tails are reported. Will this patient benefit from sperm retrieval by epididymal aspiration? So, in this scenario, 2 sperm heads without tails are reported. This is what we call spermatids with no tails, or acaudate sperm. These sperm are often seen in the setting of necrosis. Now, will this patient benefit from sperm retrieval by epididymal aspiration? While isolated sperm heads can be used for ICSI, whole sperm produce a higher fertilization rate. Therefore, in this particular patient, I would recommend the gold standard procedure, which is microsurgical testicular sperm extraction, in an effort to find whole sperm within the testicle. Epididymal aspiration is more useful in the setting of obstruction. So in a patient with a history of vasectomy or some other sort of urologic surgery, hernia surgery, where there's concern for obstruction of the vas deferens, and by aspirating from the epididymos, more likely you would find healthy, viable sperm that can be used for IVF ICSI. However, in this situation, I would recommend microtesting in an effort to find whole sperm. Question 11. We have a 36-year-old male with a history of type 1 diabetes who presents with primary infertility. There is no female factor. He reports a lack of fluid being expelled with ejaculation. He is unable to produce a semen sample for semen analysis. How will you manage this patient? So this can at times be a very complicated scenario to sort out. But what I first recommend assessing is whether or not this patient has an orgasm. For many men, they aren't sure what the difference is between orgasm and ejaculation. So in this particular patient, he does have pleasure and is able to orgasm. However, there is no fluid being expelled with ejaculation, so he has no ejaculation. So normal orgasm and no or low volume ejaculate, the next step is to assess for post-ejaculatory urinalysis. So the EAU guidelines for retrograde ejaculation are as follows. Total or sometimes partial absence of an antegrade ejaculation is the definition of this. Patients experience a normal or decreased orgasmic sensation except in paraplegics. A post-ejaculatory UA is positive if there's presence of any sperm in patients with azoospermia or aspermia. And typically, this is defined as a similar or more number of sperm present in patients with low volume ejaculate and oligospermia. So the patient should have more sperm in the urine than in the ejaculate. What are some causes of retrograde ejaculation? So some background, anatomically, the bladder neck and the internal sphincter fail to close during ejaculation, and this allows semen to flow along the path of least resistance back into the bladder. So what are some conditions that can cause bladder neck and internal sphincter dysfunction? They can be neurogenic causes. So in this particular patient, a history of type 1 diabetes that may not have been appropriately controlled over the years can lead to diabetic neuropathy, which prevents the bladder neck from closing during ejaculation and prevents the antegrade flow of semen. Spinal cord injury, multiple sclerosis, a history of retroperitoneal lymph node dissection, history of colorectal or anal surgery can all affect the nerves to the bladder. Now, medication is probably one of the most common culprits for retrograde ejaculation that I see in my practice, particularly in the form of alpha blockers. Many men are put on alpha blockers for BPH, such as tamsulosin. Tamsulosin can result in retrograde ejaculation, and all men, especially men in their reproductive years, should be counseled on that risk. According to the FDA, the risk of that side effect of tamsulosin is about 7%. Certain other alpha blockers in a similar class may have more or less risk of that side effect. Antidepressants and antipsychotics can also be culprits. And lastly, issues with the bladder neck itself, and this could be a congenital defect or a history of surgery, such as transurethral resection of the prostate or radical prostatectomy. Moving on to question 12. A couple presents with primary infertility for 2 years, and they are discussing going through IUI cycles. The male partner presents with the following semen analysis and post-ejaculatory UA. He has low volume, 0.3 mLs, with sperm concentration of 2 million and motility of 25%, with normal morphology on his semen analysis. His post-ejaculatory UA is consistent with retrograde ejaculation, per the definition, and has a concentration of 24 million and a motility of 20%. What will be your advice to this couple? So again, the EAU has guidelines in this particular situation. So post-orgasmic urine sperm collection is indicated to be used for assisted reproductive techniques if the following occurs. Any sort of drug treatment is ineffective or not tolerable due to side effects. So there are a variety of medications that we commonly use to attempt to treat a poor closure of the bladder neck. In the United States, we commonly use over-the-counter Sudafed or pseudoephedrine, and this alpha agonist can be used to potentially close the bladder neck during ejaculation to promote antegrade semen flow. However, if this fails, then sperm collection from the post-orgasmic urine can be suggested. Also, if the patient has a history of spinal cord injury. And lastly, if the patient is on certain medications, we discussed tamsulosin as one of them, or other form of drug therapy, that is a cause of the retrograde ejaculation and cannot be stopped for any particular reason. So in this clinical scenario, we want to attempt medical therapy first. We want to make sure the patient is not undertaking any medications that could be inducing the retrograde ejaculation. And if all else fails, the next step would be able to use it for intrauterine insemination. Question 13. We have a patient that had a vasectomy 3 months ago. This post-vasectomy semen analysis demonstrates the presence of rare motile sperm. How will you manage this patient? This is another common clinical scenario. Unfortunately, there are guidelines that direct our treatment. So according to the AUA, we should counsel all patients that a vasectomy should not produce immediate sterility. I counsel all patients after a vasectomy in the office that they should continue to use some form of contraception until we obtain that negative post-vasectomy semen analysis. All patients are counseled that vasectomy does not guarantee or is not 100% effective, and the risk of pregnancy after a vasectomy is roughly 1 in 2,000. I commonly check the first post-vasectomy semen analysis at 3 months, but anywhere between 8 and 16 weeks after vasectomy is the time range for the first semen analysis. I also commonly recommend patients to at least ejaculate 20 times prior to providing that first post-vasectomy semen analysis. It's not a strict guideline, but it's something that I commonly recommend. And finally, a vasectomy should be considered a failure if any motile sperm are seen on post-vasectomy semen analysis at 6 months after vasectomy. So in this clinical scenario, it has only been 3 months. There are rare motile sperm. I would recommend this patient ejaculate more frequently and have him repeat a post-vasectomy semen analysis in 1 month and reassess the concentration. A key thing when dealing with post-vasectomy semen analysis is to look at the trend. So I typically look at more than one if the first one is positive. Fortunately, that is not a common scenario. Question 14. A patient had a vasectomy 6 months ago. Post-vasectomy semen analysis reports presence of over 100,000 non-motile sperm per milliliter at 6 months. How will you manage this patient? So, per the guidelines, patients may stop using other forms of contraception when examination of one well-mixed, uncentrifuged, fresh post-vasectomy semen analysis shows the following: azoospermia, only rare non-motile sperm, or less than 100,000 non-motile sperm per milliliter. So in this situation, the patient has over 100,000 non-motile sperm. So the next step would be to repeat the post-vasectomy semen analysis in 1 month. And once again, looking at trends of serial post-vasectomy semen analysis and clinical judgment should be used to decide whether the vasectomy is a failure and whether or not repeat vasectomy should be considered. Clinical question 15. A patient had a vasectomy roughly 1 year ago. Post-vasectomy semen analysis at 6 months showed less than 100,000 non-motile sperm. However, post-vasectomy semen analysis at 1 year shows 100,000 sperm per milliliter with 5% motility. What will be your advice to the patient? Now, this unfortunately is rare, but is seen. I see this scenario roughly once a year. Commonly, the patient had a vasectomy performed elsewhere and either never had a post-vasectomy semen analysis and failed to follow up, or did, in this situation, have a negative post-vasectomy semen analysis, however, are now presenting with a positive test or causing a pregnancy. So vasectomy failure. So technical failure is characterized by persistently normal or nearly normal motile sperm counts and sperm motility after vasectomy. So this patient who had passed his post-vasectomy semen analysis 6 months would not be considered to have a technical failure because it was negative at that time. However, recanalization should be suspected if motile sperm or rising sperm concentrations are seen after an initial routine post-vasectomy semen analysis has shown non-motile sperm or azoospermia. So that is what we have in this clinical situation, which is recanalization. Recanalization can either be transient or persistent based on the results of serial post-vasectomy semen analysis. It is impossible to know the true incidence of late recanalization because post-vasectomy semen analysis is rarely repeated after a post-vasectomy semen analysis shows azoospermia or rare non-motile sperm. But recanalization is also something that I counsel patients on, the risk of the vas reconnecting, basically. While it is very rare, it is something the patient should know of. Now, our final question. A patient underwent a vasectomy at an outside clinic. He now presents at 2 years post-vasectomy to the Cleveland Clinic. He states his wife is 8 weeks pregnant. What is your next step in the management of this patient? Again, very unfortunate scenario. Hate to receive this phone call, but again, has happened. But it is important to remain calm and make sure you obtain all the information before telling the patient what is the likely cause. So one of the most common causes of this is the patient never obtained a post-vasectomy semen analysis as recommended after the vasectomy. According to the AUA, the compliance rate is roughly only 78%. So a quarter of patients do not get the appropriate semen analysis after the vasectomy to ensure a negative test. Now, in this patient, we don't know if he had a negative semen analysis post-vasectomy, but let's say he did. If the semen analysis reveals azoospermia, then the physician should inform him that the pregnancy could be due to transient recanalization. So if we repeat the semen analysis and once again shows azoospermia, however, they are certain his wife is pregnant, then there is a possibility of transient recanalization, which I discussed in the previous clinical question. In fact, a number of case reports have confirmed paternity based on genetic testing, even though the man had had multiple previous semen analysis showing azoospermia. Now, one thing you should also let patients know that genetic analysis to confirm paternity is also an option in this situation, but you should not jump to any conclusions when counseling these patients and repeat testing and giving them an informed management option is the next appropriate step. So several take-home messages from the lecture today. Let's start with leukocytospermia. So patients with leukocytospermia should be assessed for bacterial infection by PCR. We are checking for infections such as gonorrhea, chlamydia, ureaplasma, and mycoplasma. And if positive, the patient and their partner should be appropriately treated with subsequent repeat testing afterwards. The utility of semen culture is controversial, but a positive semen culture and leukocytospermia should be treated. So as we discussed, this is a situation where I do recommend antibiotic treatment. However, in a scenario where you have a positive semen culture but negative leukocytospermia, that is more likely contamination and does not need to be treated. It is important to test for sperm vitality, so you can differentiate between necrozoospermia and astenozoospermia, as the management of both those conditions is different. With necrozoospermia, you're looking towards a surgical sperm retrieval from the testicle to find viable sperm. And with astenozoospermia, you have the opportunity to use HOS, hypoosmotic swelling testing, in order to identify viable sperm that could be used for ICSI. A history of blood testis barrier evaluation may predispose a patient to antisperm antibody formation. This again is a very important past medical history that you should obtain from the patient. Any sort of surgery or trauma to the testicle can result in severe sperm agglutination due to antisperm antibody and should be assessed for. However, in this situation of vasectomy or a man with vasectomy reversal, ASA testing is not required, as there likely are antisperm antibodies due to the violation of the vas deferens and testicle during the surgery, and the treatment is a 1-month course of steroids. Now, in a patient, azoospermic male who is positive for the nuclear fast stain, this can help predict the success of surgical sperm extraction, and it's something I use on counseling patients prior to surgery. As the surgery is a significant undertaking, there is significant financial burden on the patient. There's also an emotional strain for the patient and the couple as far as whether or not sperm is found. But having this stain be positive can at least help guide the patient in making an educated decision. Post-ejaculatory urinalysis is indicated in patients with normal orgasm and low or no ejaculate volume. It is also important to obtain a good history, whether they're diabetic, have a neurologic condition, or previous surgery to the bladder, neck, prostate, etc. And lastly, when it comes to vasectomy, compliance is low as far as obtaining a post-vasectomy semen analysis after vasectomy. However, only one post-vasectomy semen analysis is needed. A negative test can show either azoospermia, only rare non-motile sperm, or less than 100,000 non-motile sperm per milliliter. That concludes the clinical lecture for today. I hope you found today's lecture valuable. Please don't hesitate to reach out. My email address is Parekh, P-A-R-E-K-H, n3@ccf.org. I'm happy to address any questions you may have. Thank you.
Connect with our program by connecting on our LinkedIn, and these are the benefits. Almost every single day, we provide update on our research activities by posting hundreds of research articles freely, completely downloadable, that anybody can read. We also post the latest research which are presented at prestigious meetings such as ASRM, ASHRI, and AUA. You can learn about our virtual research opportunities, which we have just started. You can learn about our online training and opportunities to collaborate with our team. Just go to the LinkedIn and send a request to Ashok Agrawal, and it will, from Cleveland, and it will come to us, and we will allow you to connect to our program. This is actually the best way to learn all the advances that are happening.